That's the last talk of the day, so I'm happy that so many people are with us again. And I have done research in this field for over 20 years. And when I will go away in retiring some years, I would love when somebody would remember this research, because I think this is the most important thing I ever have done. And I will explain it to you later on in the talk. So my topic is placenta accreta spectrum. And as you know, this definition of a disturbed placentation includes a partial or total absence of maternal decidua responsible for direct contact of chorion frondosum and myometrium. And in the last 5-10 years, we have two new terms. We are calling that placenta accreta spectrum or abnormally invasive placenta. So in my talk, I will refer on the past just to stay in one definition. So as you know, placenta accreta spectrum is are different grades of invasive placenta. You have the placenta accreta or creta, placenta increta, and the most advanced version, placenta percreta. And there are many factors influencing this. So when you look on this slide, you don't have to read everything. What I want to tell you is there is no big difference between placenta accreta spectrum and cancer. There are a lot of similar factors influencing development in cancer and placenta accreta spectrum. You see, this is a very complex thing. So what's about epidemiology? We are facing increase in prevalence up from 1930 onwards, from 1 in 30,000 to 1 in 300 to 1 in 1,000, caused by primary cesarean section and placenta previa. Cesarean section, much more common nowadays, you know what I'm talking about. So what are the risks in a premipara woman with placenta previa? It's just 3%, and it's going up to 60% when you have a history of 3 previous cesarean sections. And the problem is the inappropriate healing of the myometrium. So here I give you an ultrasound, vaginal ultrasound from placenta previa. And when you see these pictures, you always should think further, not only thinking about previa, but also about placenta accreta spectrum. So here, this is a large meta-analysis from 2019, where they evaluated a lot of studies, and they were able to see here a placenta previa prevalence of 1 in 1,500, and as much as 10% of this situations, they had a abnormally invasive placenta. And this means this is a big issue. And what you can assume is that, of course, the grading, the numbers are going down as more severe the disease gets. So a placenta percreta is very rare, whereas a placenta accreta is the most common abnormality here, with 60% of all cases. So again, here are some numbers, and this was a systemic meta-analysis, and which was performed to evaluate what are risk factors. This is a big review meta-analysis, and they found out that in patients who had placenta accreta spectrum without placenta previa, they had a more association to IVF. So there's more what the people from robotic department have to discuss with their patients, and prior DNC and myectomy are also increased risk. So, but also a placenta accreta spectrum without placenta previa has a better clinical outcome, despite the fact that it's diagnosed much less during pregnancy. So what else do we know? And as I told you in the last talk, I tried to find and work data from Latin America, and actually I have a study here from Latin America led by the University in Cali, and they have done a lot of research with a lot of adjunct hospitals, and basically what they figured out here in the end is that in Latin America the numbers are small per unit, and almost every hospital identify opportunities to improve the management or approach for placenta accreta spectrum in women. So this is a big point for diagnosing this entity before delivery and not have to deal with that during delivery or after delivery. And another study, they evaluated maternal death in conjunction with placenta accreta spectrum, and they found out that 87% of this death could have been avoided with a better medical management. So, of course, hemorrhage was the main cause, and lack of experience and inadequate surgical techniques were the most frequent problems. So that's the point is you need trained personnel, and again, when you're in a country which is huge and a few centers, you need to diagnose placenta accreta spectrum during pregnancy, because this will save lives. So what have we in our folder? What we can do? Of course, ultrasound. What can we see in ultrasound which gives you a diagnosis of placenta accreta spectrum? We have the grayscale ultrasound. The most known thing is loss of the hypoechogenic retroplacental zone, the so-called clear zone, a thin myomedium below 1 millimeter, piecemeal necrosis, irregularity of the bladder wall, and bulging of the placenta, and focal exophytic tumors in the placenta accreta. So I give you some pictures of that. So this is basically the clear zone. You see the black area here, and you can compress that. So this is, of course, a very slim patient, so I don't have to press a lot with my ultrasound scanner. But if you have a normal patient with a higher BMI, and you have to apply more pressure, you can mimic an absence of the clear zone. But you can see that here. Here you have a normal clear zone, and sometimes gynecologists are confused about the clear zone, thinking about detachment of the placenta or abruption during pregnancy, but this clear zone is a sign of a normal placentation. So you can display that very well. And then the point with the thin myometrium, you see here a video slide, and on the top, the placenta is coming, and this area is getting thinner and thinner. And when you look here, you have only placenta and almost no myometrium anymore. So this is the area of the placenta accreta. Most of the cases of placenta accreta spectrum are focal. It's not a total placenta accreta, it's mostly focally organized. So here again, the same video, the same picture from beginning with a placenta previa, and here you see this called piecemeal necrosis, the small holes in the placenta. Here's the cervix, so this is an anterior wall placenta, the bladder is here. And when you look very good here, you see although there's no myometrium, that means that's also a very thin myometrium. So in this video, in this clip, you see already all the sonographic signs for placenta accreta spectrum. And this is a placental lake with feeder vessels. You can see that already in the clip here in grayscale. There's blood flow going in, and you can use color Doppler, and you see how a vessel is entering this entity. So that's always a sign for placenta accreta. You have to make a differential diagnosis. You see this here, this placental legs down there. This is different. This is something else. That's what you see a lot or very, very often. It's more a normal variation. This is very clear to the fetal side. very near to the fetal side, whereas that what I've shown you before, it's in the middle of the placenta or more towards the myometrium. And of course, these are irregular bladder wall signs. You see here the bladder, and you see this black holes, and of course these are vessels. So you don't need color Doppler ultrasound. And you see here now the color, and it's clearly a hypervascularization. And even this may be very dangerous, could be the sign for placenta percreta, that placenta material is always bulging into the placenta, into the bladder. So what we can achieve with that, basically, a lot of numbers, and I know you cannot see any number from down there, I know that. So what I want to tell you is, overall, we have a detection rate with the ultrasound signs of about 90%. And when you had a placenta accreta after cesarean, it goes up to 97%. So if you have a high-risk patient, placenta previa after cesarean, you have, when you know your markers, almost every case you can depict from that. So what's about MRI? It's loud, it's expensive, it must be better. No. It doesn't give you any more information. It depends, of course, on the experience of the examiner on the MRI machine as well as on the ultrasound. But when they are all trained, there is no real difference in quality and detection rate. The only thing is that MRI may give you more information about the surrounding, but you know what an MRI machine will cost you and what ultrasound you have to pay for ultrasound. That's a big difference. So there's, of course, a FIGO consensus paper or guidelines, and that what they recommend is that ultrasound is inexpensive and widely available, and that should be the modality of first choice for the diagnosis of a past disorder. Women diagnosed with cesarean scar pregnancy in the first trimester should be counseled accordingly and followed up. During the mid-trimester ultrasound, the patient should be asked for her personal history about previous cesarean sections, and of course, it should be checked for a placenta previa. The ultrasound signs observed for the diagnosis of past disorders should be described, standardized, as I have shown you. So this is a very good protocol, and of course, the problem is there's always a subjective interpretation of the operator. So like the hypervascularization, it's very difficult to standardize this. What is an hypervascularization? It depends on the experience of the examiner and on the ultrasound machine, how they depict the color. So when you want to judge about that, you have to look for a normal placentation to learn how the vascularization is, then you can also depict an hypervascularization. So these are all very strong recommendations. The MRI for an external review it's more a medium and a weak recommendation. So the FIGO sticks to the ultrasound. And what's about early pregnancy? In the morning, I talked about first trimester fetal echocardiography. Can you also use that time of pregnancy for looking for placenta accreta spectrum? My first idea would be not really, because it's a developing problem, but there are some signs who are useful. And of course, when you have already a thin myometrium at that time, this is a sign for a placenta accreta spectrum. What's not working very well is bladder wall interruption, because this is a late sign. This is something in progress. There is no first trimester placenta percreta normally, so you have enough time to evaluate that, or you need the time. So some markers are working in the first trimester, some not. But we know a lot about that. This is not new. How it works in the real world. So this is a study from the UK. The UCOS study, very famous after COVID. Big database, and what they figured out is, despite all the knowledge about placenta accreta, just 50% of placenta accreta spectrum in Great Britain was diagnosed before pregnancy, despite the fact that everything was known, how you can do that and who are the risk factors. And of course, they figured out that those who are diagnosed early benefit from the diagnosis. Surprise, surprise. So that's a very big point. So there still is a need for training, not only in Latin America, everywhere, to be honest. So there were recommendations from the HOC 2019 about how you could handle the patients. Of course, it's all about definition of a center. And you see here all the recommendations, what you need to have a proper center. And when you look up that, all the details, urologist, neonatologist, vascular surgeon, colorectal surgeon, hematologist, you need a big, strong hospital for that. So that means, of course, again, there could be only a few centers in a country. So you need to diagnose that before delivery. And you won't succeed or you won't improve without prenatal diagnosis. So that's very important. So what is the management when you diagnose that during pregnancy? It's an outpatient management. You go for a primary cesarean section. It's 36 weeks in uncomplicated pregnancies, a little bit earlier when you have complicated cases with prematurity. Of course, again, patients coming from somewhere out of the woods, and then you need to, she has to go to her center for that, so you have to plan ahead. Some of the stands are not routine, balloon cath, things what you can do to avoid bleeding of the patient is not a routine. No routine vertical midline incision according to recommendations. So what's to expect? You can choose an expectant management, leave the placenta where it is after delivery, and that works very well. Or you have a focal placenta, Accreta spectrum, which is the most common case, and then you can try to have a local resection of the uterus with the placenta, just reducing the size of the uterus, and they can still be pregnant afterwards. So what's about life-threatening, massive hemorrhage? There are different options, balloon tamponade, everything, medication. Of course, emergency hysterectomy if there's no other solution for that. So, but what's about the 50% who are not diagnosed before delivery? What we do with them? And here are the recommendations again, and there's just a small sentence about that an experienced examiner should evaluate the cleavage plane and may make clinical diagnosis. What's about ultrasound? Nobody's talking about ultrasound in the actual guidelines. And we know much more since 30 years, but they are not implemented. This is the kickoff picture for a research started 30 years ago, almost exactly. This was a woman with a hemorrhage delivered, and it was bleeding, and the attending on call was an ultrasound guy. And before she went to OR, he did an ultrasound. He figured out there is blood supply to the placenta. Is this normal? Is this not normal? There was no research, no paper. So what this was, the kickoff is about how works third stage of labor. What happens with the placenta after delivery? Look up in the books. These are the classical things. You know, everything old medicine is German. Looking 1900s, 2000s, early 2000s was Germans. Here, the third stage of labor, according to Schulze, that's in the books. You have a retroplacental hematoma, and this is the kickoff for abruption or separation of the placenta. And there's the Scottish guy. He said, no, yeah, we have this lateral separation and no hematoma. So that's what was in the book, or is still in the books. Then I digged further in the literature, and look here, in the 20s, over 100 years ago, they did X-ray, and look what the placenta looks like after delivery, and what they figured out with X-ray 100 years ago. There is no retroplacental hematoma, and the separation is completed after 3 minutes. They always found that they switched on X-ray after delivery and they just found a separated placenta. But there was no retroplacental hematoma. So there's something wrong. So we went back to this picture and thought about what is the meaning of this. So we did a lot of studies, and this is not digging numbers from databases, this is real work. You're sitting next to the woman before she delivers, you're setting up your ultrasound machine, and you're waiting for the delivery, and in the moment the baby pops out, you put your transducer on and visualize the uterus and the placenta and look what you're doing. So we did that 120 times, and what we figured out is that the separation of the placenta is very uniform. You see the placenta here on the anterior wall, and the detachment always commences from the lower pole. Patient is moving, sorry, and you see this. There is the first sign, and like a zipper, now the uterus and the placenta separates, and what you have seen maybe also is that the thin uterus getting thicker, the contraction kicks in. So this is the separation of the placenta, and funny thing, 120 patients, always the same. And where is the retroplacental hematoma? It's not existing. It was just a theory from the 1900s. It was copied in every OB book, but it's not existing. There is no retroplacental hematoma, never been. So we made a calculation of the length of the third stage of labor. And what we figured out first, is that there is no blood flow. It terminates right away after delivery of the baby. There is a termination of blood flow between myometrium and placenta. No blood flow at all. So this gives you a hint why in the case was blood flow, what a kind of diagnosis this might be. And then we had a latent phase, nothing happened, separation phase, expulsion, active, and the whole third stage is about 6.5 minutes a total. And the 95th percentile is 15 minutes. So when you wait beyond 15 minutes, everything else is just logistics, that you have no time for the patient, but there will be no deliverance of the placenta afterwards. And also we measured the thickness of the myometrium, and that was that was a good number here, are 15 millimeters. The 95th percentile before separation is 15 millimeters. The 5th percentile after separation is also 15 millimeters. So that means when you have 50 millimeters, that's your cutoff to make the call. When it's 15 millimeter or thinner, you can assume there is a placenta which hasn't separated. And when it's thicker than that, you have a separation of placenta. So when we look on this video here, you see the blood flow from the myometrium going through the placenta. There shouldn't be a after delivery blood flow. So what might that be? Placenta accreta spectrum. That's it. You see the placenta here because it's granum grade 3, so that's nice to pick the placenta. So we can use, during third stage of labor, we can use ultrasound for the diagnosis of placenta accreta. We have a persistent blood flow between myometrium and placenta. We published 20 cases about that. They were all the same, 100% detection rate, confirmed by histology. You have a thin myometrium below 10 millimeter, you know it's obviously a placenta accreta. And the management options are, when you know where it is because of the ultrasound, you can go for a targeted management, even targeted curettage, and you can preserve the uterus. So that's what we know since 30 years. It's not in the books. The research was, we did that for years, and then it's going away because nobody's listening to that. So, but this also helps you after delivery. Many of you are working in a hospital or a private setting, and there's a patient delivered 4 weeks ago, and she has still a bleeding, and you don't know what to see. So this is a picture for that. This is just one case on the final. So you see the ultrasound, and with this, you have the definition and the diagnosis already. What you see here is a thin myometrium. I measured that below 1 centimeter, 8 millimeters. So this is enough to know. So we have a placenta, accreta spectrum in this area. And then look at this black holes. There is blood flow, a lot. This is the blood flow. It's a hypervascularization. So this is your diagnosis. This is a placenta accreta spectrum. The history of the woman was deliverance. She was delivered. She had a bleeding. She had a curettage. Another bleeding, a curettage, bleeding, curettage. She needs transfusions a lot, and she was discharged with a stable disease with a hemoglobin of 5 point something. The diagnosis was missed 4 weeks later, or 3 weeks later. She came in my office. She was stable at that time, so we thought about, now it's stable. Just wait and see. So she come by after 8 weeks. You see the uterus still. You see placenta rest, and blood. You see the blood flow is decreased a lot. So that's the natural course. After 16 weeks, it's almost gone, and after 4 months, so this should be more or less a normal uterus without hypervascularization. So we can use the knowledge of third stage placenta ultrasound evaluation also in the postpartum period to evaluate whether there is a placenta accreta or not. And after 6 months, everything was fine. So I conclude, we need prenatal diagnosis of PAS in high-risk pregnancies to save women, especially in rural settings where centers are sparse. There are standard protocols for intrapartum management. You need, accordingly, a good setup for that. And what's important, when you're missing the diagnosis of placenta accreta spectrum before the delivery, you should be aware the signs of PAS during third stage of labor to avoid a great blood loss and loss of the patient. Thank you very much.